Hello and welcome back to the Advancing Healthcare Innovation Show. I am your host, Michael Stamatinos. And if you're new to us, welcome. We are so glad that you are here. We're having some incredible conversations with real leaders that are painstakingly reshaping the future of healthcare. So we're pretty passionate about a few different areas. We're passionate about access, about leadership, about innovation, and the adoption of those innovations. And if it's your first time tuning in, let me just take a quick step back, give you a little bit of the rundown of what we're really trying to get done here. So, our focus is on bringing real stories of innovation to life, not just the stuff that you read in headlines, but real people that are really truly innovating in the trenches. What's working? What are some of the learnings, and giving them the opportunity to sort of share those things with our community and ultimately with the world. If you haven't had the opportunity to check out any of our historical interviews, however you're watching this, if you're watching it or if you're consuming this or listening to this, however you are consuming this, please hit the subscribe button now so that any of the new episodes come directly to you. So I'm actually really excited about today's conversation for a few different reasons. Generally, we do conversations prior just to kind of get to know you, and then there's usually kind of get to know whether or not, like, if you really gel with someone, and this person really gel with. So Dr. Jenni Gudapati, she started out as a nurse. So she's been in the room. She understands care delivery at a very deep level, and she's seen what good care looks like. And at the same time, she's seen it when things kind of fall apart. And she went on to build a graduate program at Boise State University that won not one but two national awards. She co-chaired Idaho's telehealth task force, and she was picked by the Centers for Medicare and Medicaid Services to help write the health equity standards that health plans across the country have to follow today. So she's trained healthcare leaders, she's worked with lawmakers, she has spoken at conferences across the country. But I think here's what drives her: the people who've been getting left behind, seniors, people in rural towns, people dealing with complex health conditions, people who had insurance, had a care plan, were supposed to get help, but never did. And now she's gone on to co-found a company, Healthy Insights AI, a company that is built on one belief: that every patient's story deserves to be seen, and that the care people are promised should actually reach them. So she's helping organizations generate insight, not just by working with one insight alone. That's obviously not enough. But what does it actually take to move a team from knowing about something to actually doing something? And I think if we're honest, in healthcare, we don't have a shortage of information. If anything, we have a sea of data that we're just not seeing. And I think folks are having a harder time now more than ever with trust and alignment and ultimately, action. So what I'm excited about today is kind of digging deeper, what has shaped her perspective, some of the stuff that she's seen early on that she still holds true, and maybe where she believes things tend to break down, even in well-resourced organizations that have all the data in the world. So that's what I'm really excited about. Jenni, it's great to see you. Welcome to the show.
Hey, thank you, Michael. Thank you for having me. I too was excited to be on today. I think the last time we talked, it's very rare that you meet somebody and all of a sudden your entire scheduled time is gone because you've talked so much. And, when you have the energy level that I do, it's also kind of rare to meet somebody where that energy and the passion for better healthcare is
Yeah,
equal to mine.
yeah,
And I felt
yeah,
like when we connected, it was just a different level
yeah.
of people that really care about where healthcare should be going and excited about things that are moving in that direction.
Yeah, the kind of the universe is scheming to have us jam out together. So that's interesting. Before we kind of dive in, I kind of want to start where most people don't start, because you started off as a nurse, as a clinician. Um, you got to see things that others don't necessarily get to see as a frontline care delivery worker. What was it like, just sort of being bedside in rural America?
Yeah, that's a great question. And, you're right. I mean, I think I've been, so much in value-based care and trying to change things on the healthcare payment reform kind of things that I think a lot of people tend to forget that I started out as a nurse, right? So I began my career well over 2 decades ago in the emergency room and critical care departments of, I'm going to do a shout out, Holy Rosary Medical Center. It has since been bought by a larger system, but all of us in Holy Rosary remember the days. And, I think everything that I learned, both at the hospital and then when I left in the hospital and got into home health, really drives what I do, right? As an emergency room nurse and then seeing our critical patients in the hospital, what I really saw was the same patients bouncing back and forth into the emergency room time and time again. And the viewpoint was, we see these patients and oftentimes, they get misclassified as like, oh, these are our frequent flyers or these are our non-compliant patients. And I think the thing that I've learned from being at the bedside, being from the health system, and then going into the patients' homes is we didn't understand our patients, right? Like when you go to nursing school or medical school, we are really, really good at teaching body systems or chemistry, or these are the way things are, and this is why this lab is going to create this result. But what we haven't done really, really well is taught clinicians on how to actually listen to their patients. And that's so much outside of just the physical properties of a patient really dictate how they do in their healthcare environment. And I think, a lot of what you've touched on already, like how much the patients trust the system, or, what are their social needs, or what are those things? They are very, very large factors in how patients are going to respond to care, whether or not they are going to be accountable in their care. And that's what really, I think, for me has driven my career on how do we bring our patients' stories into our care planning so that even though we may not always agree on things, like right now you bring up trust, right? Like if I sat down with 10 patients, I'm going to have 10 different views on what they think they need to make their health most optimal.
Right.
So let's see if we can sit down and work together to figure that out.
Was there like a specific moment or maybe a patient or a situation, I guess something that made you kind of realize that this problem is actually way bigger than what you could sort of fix from the bedside?
Absolutely. I have one patient in general that I will change everything about them just because of HIPAA, right? Like I hate for my patient to be listening to your podcast and be like, I think Jenny's talking about me today. But I had one patient in particular that used to come into the emergency room quite frequently. And, they would come in and always complaining of, we'll just say today it's back pain. So they would come in time and time again for back pain. And so one night in the emergency room, because I am a night shift emergency room back when I was at the hospital, I was one of those crazy. But one night we were swamped. I mean, we had a lot of critical patients. We had a backlog. And this patient came in and, to my embarrassment, I walked in, I was a little bit frustrated, and I sat down, and we'll just say that today her name is Sally. Sally, did you make it to the pain clinic? Did you make it to physical therapy? All of the things. And the patient looked and she was, no, Jenny, I didn't do that. I didn't do that. And so in my frustration, because as a nurse, we are a lot of times under a lot of stress. You're running in and out of rooms. You're trying to take care of a lot of patients. And so here was a patient that, number one, I didn't see as critical as a lot of the other patients in there, but one that I just didn't feel like she was listening to what we should do. And so, I'm kind of like, why didn't you do these things? Like we've sent you, we've given you our instruction. And, she looked at me and she's like, Jenny, you're right. You see me a lot. I request you as a nurse. And she goes, because when I come in, you give me a sandwich, graham crackers, and a carton of milk. And she goes, sometimes I don't come in the emergency room because my back is hurting. It's because I'm hungry. And that one moment changed the entire way that I saw discrepancies in how we should be caring for patients, because I had never thought to ask our patients, like, they say they're coming in for one thing. Can I assume that? And so as the evening rolled out, I realized she didn't know how to fill out her paperwork to get the services that she needed.
Right.
And so I called in social work in the middle of the night and said, I am going to get this patient taken care of. We are going to get her signed up. We're going to get things taken care of. And what was interesting is, of course, as the days played out, I'm thinking, I am going to get the Daisy Award for this, right? I have gone above and beyond the call of duty. I have figured this out. I called in social work, and instead I got in trouble, right? Because I called in an unnecessary social work visit into the middle of the night. So not only did it cost the hospital more money because it wasn't a reimbursable reason to call a clinician, but they had to do so at after hours wages. And what was interesting? I could have been mad at the hospital. I could have been mad at my supervisor for letting me know that is not something I should be doing as a night shift emergency room. But instead, I really explored the problem in a much deeper realm, which is, why didn't the hospital get reimbursed for this? What do we mean? Like, this was an expense that if you look longitudinally, by getting the patient's needs met, we stopped so many unnecessary ED visits for this patient. We actually gave her the ability to get, what she needed in a much more appropriate manner, which was truly the services that should have been provided to her the first time she came in. And so it led me to leave the hospital and get into home health. So I got into post-acute care. I became the admissions nurse for my agency. So I got to go into the homes of the majority of our patients, do the initial assessments, and then write a 60-day care plan for them, right? How do you go and admit a patient in a couple hours and figure out what their needs are over 60 days? And through that experience and having the ability to talk with my patients, because those assessments can take 1 to 2 hours, right? By the time you're there, you're doing this with your patient.
Yeah, but you're also observing the environment too. Like you're they're saying things, but you're also kind of seeing things with your eyes, and you're kind of putting all this data together.
Oh, absolutely. And things you'd never think of, right? Like, I would walk in and find patients who, in the emergency room, we saw with diabetic ketoacidosis, only to find out there was no working refrigerator to house insulin, right?
Yep.
So it wasn't that the patient wasn't trying to take the medicine. It was just that it wasn't effective. Or I would see patients that would cut their medicine in half, thinking they would only have to buy the prescription once every 60 days instead of once every 30 days because they couldn't afford to take it on the regularly dose schedule. And they thought that was the best thing that they could do. And so it really did open my eyes to how can we change the way we view healthcare, the way we pay for healthcare, to where we work together to incentivize best patient outcomes without waiting for our patients to get sick or need emergency medicine.
So is that sort of a nice on-ramp to, because you're now going from bedside, you transitioned, you're doing, your doctorate and then some other additional postgraduate training. It seems like, did that sort of accidentally happen? And guess what were you trying to figure out that you couldn't see from where you were at that moment?
Yeah, I think there were a couple things, Michael, that changed the course of the career. About that same time, I also lost my father. And I lost my father, in my opinion, in a totally avoidable secondary stroke situation, where he was discharged from a hospital with no post-discharge coordination. So they had changed his medicines, or at least the dosages, and forgot to tell his primary care provider. And so when I brought my dad home, I asked him, did they change your medications? And he told me no, because they were the same medications, but I didn't think to ask him, did they change the doses? And so my
Sure.
dad had initially gone in for a blood clot because his blood was too thin. They took him off of his blood pressure medicine and up his Coumadin in the hospital, then forgot to tell him to go back to normal dosages and said, hey, when it's time to get back to your normal doses, your primary care doc will reach out to you. And so my dad, 2.5 weeks later, had a brain bleed. And I figured if this could happen to me, an emergency room, critical care certified nurse, who also is in home health, and I let my own father, who was my best friend, fall through the cracks, what is happening to the rest of the country? And why don't hospitals at that time get paid for discharge planning? Why is it that they only get paid when patients are sick or hurting? And so I started to investigate, learn about value-based care, things like remote patient monitoring, post-acute care. And that's when I became passionate and kind of started the mission of, I'm going to change healthcare, right? Like, I've lived it, I've seen it. It's time for somebody to start doing something about it. And so it became a personal mission of mine to change the way we get better healthcare, which, in my opinion, the only way to do that is by changing the way we pay for it.
Pretty fascinating. Do you, in terms of where you are now, are there certain things that you kind of used to believe, and now that you understand how money flows, how policy works, that you kind of completely changed your mind on?
Absolutely. I mean, I used to think that, the answer is to just start pointing fingers, right? Like, why do hospitals charge so much money? Or why are they only taking care of patients that are sick? Like, why aren't they doing case management? And then at the same, time, you blame health insurance companies that, are maybe denying claims or, require prior authorization. And what you realize is, in my opinion, I don't see that there's any real enemies at all in healthcare. What we have is a system that just don't have guardrails in place that are appropriate, right? Like, so for a while, health systems would, they would charge for every single good or service provided, right? And so the more goods and services that they produced, the more money they made. So what happens? Insurance companies are like, wait a minute, you're ordering all these goods and services, sometimes, multiple echocardiograms in a week, or why can't we share health records so that we don't have to do repeat testing? And the reason is because it's what drove revenue for their system, right? It's what kept their doors open. It was what they needed to do, or even just didn't think about it anything else. Like, as an emergency room nurse, I can tell you there was a time where I would bring in 4 IV start kits, not thinking that the patient was going to get charged for 4. But I knew if I brought in 4 IV start kits, I'd get the IV on the first stick because, they'd have extra. And if you only brought one, the IV gods were going to make me miss, right? So I'd have to leave the room and get another IV start kit. And so I never thought about cost containment for practice, right? It was just this different type of thinking. And I think when you look at healthcare, both on the delivery side and the payment side, it's just like everything else. It works in a pendulum, right? So we had a health system that were charging for the goods and services that they were delivering. I want to believe that it was not done out of ill intent. It's not like they were trying to make people go bankrupt across the country, right? They were doing what they were doing on the easiest manner possible, right? Yeah. There's a lot of times it was easier. Like, if you go to your primary care doc, you find out you've got a cardiac diagnosis, they do an EKG. Oh, there's a problem. Let me send you to the cardiologist. You go to the cardiologist. He'll repeat the EKG. He'll repeat these studies without ever thinking that even our Medicare patients a lot of times have to pay 20% for every single time they get these services done. And so, I believe it was not due out of ill intent. It was just due out of ease and just doing what we could to try and get care done as quickly as possible without the thought of cost containment strategy. And then on the payers too, I think the payers get labeled a lot as the bad guys. especially in today's world, the big guys are like, oh, all they care about is their profits. They're denying all these services. And to some extent, some of that has happened too. But I don't think that's what gets all of the people in the insurance companies up every morning to say, I'm going to see how I can deny someone's healthcare coverage today. I think with that, we had all of these repeat tests and studies coming in and excess goods and services that maybe weren't needed for our patients. And so again, they were given the authorization to do things like prior authorizations or denials. And so again, without guardrails in place that said, you know what, you can't just deny care, right? You can't just do this.
Right.
And so that's why I think healthcare should change. And I think we're moving in the right direction. I mean, I'm a huge fan of managed care programs, whether that be managed Medicaid, whether that be managed Medicare. I was really pleased to see the final rulings come out for the Medicare Advantage programs because I was a little bit nervous as far as what that was going to look like. And I think what this does is that when you have a properly managed population, right? If we get into population health, that's where the beauty comes in, right? You've got your payers and your providers hopefully working together to promote the best outcomes of our patients based off an accurate risk of patients, right? Not one that is mined out of charts with AI software that looks for every single diagnosis that patient has had for the last 5 years that you can pull a hit code off of. But when you're really looking at how do we take care of patient risk together to promote what's best for the patient and do it at the most cost containment, methodology that we can come up together, that's where I think population health management comes in. And I've seen it from, my early days in the bedside. It's really just changing the way we think.
It's so interesting you bring that point up because it's like we're in this moment now where, like, I don't know if it's everyone, but a lot of people are talking about, data, AI, insights, and yet you still like walk into rooms where people look at the same metrics, and yet they walk away with different conclusions. Like how does that happen?
Well, I think I took statistics, right? I've got my PhD. You can take data and make it look any way you want to.
Yeah, I guess what I'm trying to say
what you're trying to find.
Is that a data problem or is it a people problem?
I think it's a combination of both, right? Like if I'm an insurance company without those guardrails in place and I'm trying to take care of these patients, I am going to try and get that money so that I can hopefully provide as many resources as possible, right? When you look at a risk-based arrangement, if you could think about it as patient risk and identification of patient risk, it's supposed to give a little bit more reimbursement so that you can make the resources available to your providers to take the care that they need to slow down or stop the progression of disease exacerbation, right? That's the idea of risk. And so, what it's turned into is, to your point, like data, where we're going to look at this data, we're going to pull this data, and we're going to try and show this made up risk score for a patient that, in all honesty, has absolutely zero meaning to the providers, right? There's nothing in a risk score that talks about intervention or what the provider is going to do. So if let's link our risk score on interventions or care planning that can make a difference. And I think that's hopefully, the route that we're moving towards. The other thing about data, which as we look at the current systems and some of the problems I think with risk scoring that we have, is I don't know how much data is actually created by the patient, right? That's the whole reason why I created Healthy Insights is very rarely is it the patient themselves creating their own data about their current conditions or about their own health or their own life needs or their social needs. And so I think if we really want to create accurate data, the most accurate way to get that data is from the patients and the caregivers of the patients themselves. And I think that's when data can become more reflective and a truer picture or snapshot of the patient condition at that given time.
Mm. Because you mentioned healthy insights, it kind of triggered a thought in my mind because, look, you're a tenured professor, um, nationally recognized program director. Kudos to you. You're building something very real at Boise State, and yet you've found time to co-found a company. I guess what was going through your mind when you decided to kind of make that call?
Yes. So first off, I'm not tenured. If there's anybody that I work part-time at the university, I created the
Okay.
master's degree program because I saw the need. So, my heart is truly in transforming patient care. And so I created the master's degree program to teach the next generation of leaders on population health management. And I employed, most of them all are volunteers, right, that have given their time to be guest lecturers in our program, the top of the top, the best of the best to teach how to do this,
Yeah.
right? So we're not sitting in siloed systems. And so as I was recording all of these guest lectures, the one thing I try and pride myself on every day is I think I know a lot about healthcare, but I don't know everything. And my curiosity and passion to make it better has really driven me to listen to those that are doing it correct. And so as I interviewed all of these top healthcare experts across the country and even a guest lecturer, head of value-based care of Europe, I listened to see what I could learn from them because I think,
Yeah.
so many times we solve problems and then we never hear about it. And what I heard time and time again is the same argument, right? But on opposite sides. So here I'm just this neutral gal in Boise, Idaho, recording the best of the best. But the complaints of all of the providers were the same. The
Right.
complaints of all of the payers were the same. And it was really the disconnect in how do we get accurate patient assessment. And to me, it was like, well, that's a pretty easy problem to solve, right? Like we know, I have guest lecturers that say that the true way to be successful in value-based or risk-based contracts is annual wellness visit compliance. And it's taking the time to get to know our patients, right? But then at the same time, providers get on there and say, that's great. We all know that would be the dream. Unfortunately, across the country, we have less than a 30% compliance rate for annual wellness visits.
Is
And
that
the
really
reason
it?
is because of
30%?
yeah. Yep. At the time of my guest lecture, he had a slide. So,
Yeah. It's low.
and even if we get those numbers up there, they're not, a lot of times annual wellness visits are done to check a box, right? They have to get them in. They're under contracts where it's imperative. But what I heard from the providers, is we're doing the best we can. We all know that there's a workforce shortage. And we all know that to do these assessments, the administrative burdens can take up to 45 minutes to an hour of my clinic time. And under a current RVU system, I'm expected to see 18 plus patients a day.
Yeah.
How can I spend 45 minutes with this patient collecting all this data? And then at the same token, health insurance companies have to do a health risk assessment of their own to do a lot of the same things for the quality measures that insurance plans are governed, under NCQA, you've got to do this, you've got to do this. And the rate that, beneficiaries send in their HRAs are pretty low. So there's plans that pay providers to try and fill the HRA, or they'll send people to patient houses to try and get these done. And so, I'm a big believer in telehealth and telemedicine and technology. And so as I kept hearing these stories from payers and providers, I was like, gosh, has anybody really listened to each other? It would be so easy to solve this problem. Let's screen patients before the visit. Let's meet the requirements of an HRA. Let's get all of that information before the visit so that the provider, when the patient comes in from their annual wellness visit, they could have a report that gives them that snapshot with all of the caregiver concerns, all of the patient concerns in an easy to digest report so that the annual wellness visit or other screening visits, depending on the age bracket, could actually be done for the provider to correctly diagnose their patients,
Right.
correctly understand where their patients are, and use that time to make a plan through shared decision-making with their patients that promote best outcomes with their patient, reduce screen time, and actually make healthcare collaborative.
Yes.
And as I started talking to people across the country and saying, hey, what are your ideas? They're like, oh my gosh, Jenni, this is great. Like this would help me so much.
Yeah.
And so, I dropped down to part-time at Boise State. I was thinking this was going to be a great job to cruise along. Dropped down to part-time and said, well, I'm still going to teach. I'm still going to do this program because it's important. But I'm also going to found a technology solution to give patients their voice, reduce the burden for providers, and at the same time, hopefully give that documentation to payers need to get an accurate risk score for their patients to be able to provide those resources to providers for better care management, but do it in a meaningful way that's allowing the patient themselves to enter into the equation and not just be a couple of digits on a piece of paper or across a computer screen.
So, I mean, I'm loving this conversation, and it's like your nurse is coming out. That persona is coming out, and there's a page on your website called like the nurse's story, and you basically you describe the platform as something as like it behaves like a great nurse, and I love that, by the way. What does a great nurse notice that maybe a great algorithm still misses?
Yeah, that is the things that, honestly, the story behind the number, right? A great nurse or a great clinician of any kind, because I've known, a ton of great providers, whether it be respiratory care or x-ray technicians, right? That'll come in and be like, Jenni, I noticed this on the patient. It is looking at the things that are outside of the norms, right? Like I mentioned, the time that, luckily being a home health nurse where the patient could be coming in a lot of times with high blood pressure, right? And their blood pressure keeps going up and up and up and up. But it's the nurse or, the true reflection of, are you able to afford your medications? Is that the question that's been asked, right? Because I've seen with my own eyes, patients cutting their pills in half to try and be able to afford their medications without thinking maybe the reason that their blood pressure is not getting controlled is because they're not getting the correct dose. And a computer doesn't think that way, right? It's just going to look and say hypertension, hypertension, hypertension. But it's that critical thinking and assessment skill that data doesn't provide. And only the patient can truly provide that story behind those numbers.
Speaking of stories, so you were selected by CMS to basically help write health equity standards for the whole country. It's kind of a small role, right? I'm just kidding. So it's a big task. Okay. And that's like a really big room to be in. I guess what like surprised you most about how people, in those rooms at that level think about this problem?
So I have questions. First, if you're referring to my previous appointment, I was on the CMS technical expert panel, or if you're talking about the HHA advisory committee I was just appointed to.
Well, both,
or the Department
because
of Health and
obviously
Human
those are both important rooms to be in. I mean, just kind of give both. I mean, I feel like context to both probably applies.
So in the CMS technical expert panel that I was able to serve on, I was nominated for that position by the at-time director of health and welfare for Idaho, David Jepson, and they were looking for somebody that had like home health or hospice expertise with policy to really look at health equity and quality standards. And so, Dave had reached out and he's like, Jenni, what do you think? Like, this seems like it's right up your alley. And I'm like,
Yeah.
Dave, let's go for it. And so he had nominated me and I was selected. And I think what the cool and interesting thing for me when you sit in a room like that, because there's all these really smart people from around the country, right? And they're trying to look at health equity, is so many times we look at health equity through our own lenses. Like, what's our passion, right? Like, even myself, I'll admit I can be biased, right? When I hear health equity and quality, if you are not talking about seniors and Medicare, okay, whatever, right? Like,
Yeah.
I am thinking of rural seniors and the patients
Yes.
that I took care of for years. And what was cool about being in a room like that is being able to move outside of your normal passion for these type of topics and listen to others that are like, I am worried about, like these underserved populations for like pediatric in urban areas, which as a nurse, where most of my clinical background, I was living in Weiser, Idaho, I had never gotten the opportunity to hear those stories. And so you realize in those conversations that what you see as, not equitable care or difficult access to care,
Yeah.
in my mind, when I think about difficult access, it's 150 miles from my patient's house to a doctor.
Yeah.
But for me to hear that there's this kid in like downtown New York or something that can't get to a pediatrician, that's when you really start seeing that if we could, understand the true access problems and look at things like technology and telemedicine and all of those things, the problems are very, very similar. And so I think that's the coolest thing about being in those committees is you start to see a much larger
Yeah.
problem than what maybe you've seen in your own backyard, if that makes sense.
Yeah. Do you feel like now, as a part of being in those rooms, like your pattern recognition is even greater, and then you kind of go back and you then can apply it, and obviously being able to teach those skills to your students, because it's not just about you. Now
Oh,
you're like, hey, I've got generations of other leaders that are behind me, and it's like if I really want to make an impact, it's like there's only so much that you can do as an individual, but if you want to see exponential, it's really about those next line of leaders that are coming through.
oh, 100%. And, I think, you can get me excited because that's why we created this master's degree program. I mean, we have like great people like Gordon Chen, he teaches a lecture on healthcare transformation, and Sachin Jain on Medicare Advantage, and, Kimberly Brandt teaches a class in healthcare law. And out of all of these people that I reached out to, no one said no, Michael. When I said, hey, I am trying to create a program to teach the next generation of healthcare leaders, all of these greats said yes. And it let me know that those of us that have been in it down and dirty, we've learned what
Yeah.
we've learned, we've fought the battles, and we need to pass those learnings on. And what's incredible is the students that have graduated from our program are doing incredible things. Like, they are becoming leaders within their organizations. And, I advise all of the students, probably because I'm selfish and I want to be able to advise all these students and we stay connected. And so,
Yeah.
they'll text me or call me and, Jenni, we're doing this, or I just got pulled into this meeting because I view things differently. And so it's, again, that's where we initially thought about it. I don't think healthcare has ever been ill intent, because if so, I would never have become a nurse, right?
Right.
I want
Right.
to help
Yeah. Yeah.
people. And
Yeah.
I believe everyone that gets into healthcare wants to help people, but it's just changing the way we think to a different mindset. And I think our students are getting that, and they are leading their organizations and doing wonderful jobs, which makes me prouder than any accomplishment I've ever done myself, right? Like, when my students call me and they're like, Jenni, would you write a letter of recommendation? I'm up for this, or, can I put you as a reference? 100% all day long, yes, because I know that they have the skills to really change
Yeah.
and move the needle as we transition.
Did you realize back then, as you were pre-selecting these rock star kind of folks that are going to come in and lecture and become these guest lecturers, did you realize back then, like, hey, these relationships can be springboard into what I'm doing with Healthy Insights AI? Did you sort of see that many steps ahead, or were you just like, hey, these are some great relationships and we have a good foundation, and I see this gap and I feel like I can close this gap and I'm going to kind of leverage these relationships? Or was this part of your grandmaster plan?
No, no, in fact, quite opposite. In fact, you know, I was hoping to stay full-time at Boise State for at least 10 years for my PSLF, right, to get my student loan paid off. So having to not stay at Boise State full-time for 10 years really was not financially the best decision. But no, I mean, joking aside, no, I mean, I literally, when I took on the task and, you know, was given the opportunity by Boise State, and then we partnered with Healthcare Financial Management Association, I had
Mhm.
just felt like I was given a gift, right? Nobody is given a directive like, Jenni, just do what you want to do. And that's what the leadership did. And so I took that very seriously. I have colleagues that help me that actually are core faculty, you know, in the program that I'd known that were great, that I knew would also want to do it. But then as each week, as we were planning out the course, and, you know, like I'm trying to figure out, I am not an actuarist. Who should be the best actuarist to teach, you know, in this week,
Yeah.
or this week?
Yeah.
Because we have core faculty that, you know, work with the students every week, have a live Zoom session because it's an online program. But then each week I wanted to find like the area industry expert for that topic. And so it's like, who's the expert on actuary? Well, shoot, you know, I stalked LinkedIn. Like, I'm surprised someone did not file a restraining order. And I find this guy, Dave Dillon, right, who's now president for the Society of Actuaries. I'm like, I think this guy's the best. Let me message him and see if he would do my guest lecture. And, you know, next, it was like Brian Sweatman. You know, I think he's chief actuarist and principal for Milliman, right? Like, hello, Brian, my name's Jenni. You know, basically, I'm trying to change the world. Will you help me do it? And, you know, it was all out of trying to find the best of the best people. And the fact that so many of us now, I think our colleagues and friends, was totally unplanned. But again, I think it has to do with when you meet people that are so impassioned to change and believe in our hearts that we can do better, it just creates its own network. And I think that's kind of what we have created, is just a network of amazing people that believe we can do better for our patients.
So I hate to break it to you, but that is entrepreneurship. You basically, at that point in time, you didn't realize it, but you were like doing your training, but you were given this task, building this program. Essentially, you're an entrepreneur, and they came to a point where like, all right, here's the vision. Who am I going to get? And you find the best people because you cast the vision. People get excited about it, and they come like, oh, of course, I want to help you. Of course, I want to help you. You're using those same muscles as you're building your company now, because it's those relationships like, hey, I want to change this world. I want to make things better. And here's the vision. And here's why I'm excited. And here's why I'm passionate about it. And what happens is people, they gravitate towards the passion. Like no one ever got excited about someone who was not excited about something. If you were just like sitting here and like, yeah, you know, kind of doing this, it's okay. It's fairly decent. But it's like no one's going to be excited about that. However, on the other hand, I mean, you radiate passion, joy. That's like a superpower. And I'm just saying that as another person on the other side of the screen right now. But that's definitely a superpower. And that's a way for people to say, I don't know what it is, but I want to kind of be there because like she's onto something. It's kind of cool. It's cool to see it. It
Well,
really,
thank
really
you.
is.
Thank you. Thank you. And then but one more quick thing, because we are going to bring up the appointment to the
Yeah.
Department of Health and Human Services and CMS Advisory Committee that I was just appointed to. Again, like honestly, it's still surreal to me, right? Like I look at all of the other people on this committee that I'm with, and they're all like really famous, right? Like I think I got a notice from LinkedIn after it was announced, like, Jenni, you have one of the most viewed LinkedIn profiles today, because I know everybody's like, who's Jenni Gudapati? Like, who is this girl? Like all these other people we know. And what's the coolest thing about this appointment? And, I think which, again, in my opinion, shows that we want to change is how cool is it that Dr. Oz and, Robert Kennedy picked a nurse from Weiser, Idaho on this committee to say, like, Jenni, we want to change health policy. Like, we want to understand where does the rubber meet the road, right? Like, what does that look like? And I still just can't believe it. Like, I have not only my voice, but all of the providers I've worked with, all of the
Yeah.
patients that I've
Yeah.
worked with for nearly 3 decades, and the 80 people that volunteered to help me build this master's degree program. I hope I can bring their voices into that room, because I truly believe, Dr. Oz called and interviewed me the day before Christmas Eve. Like, that's how dedicated these people are, right? Like, he's calling me 2 days before Christmas, and he was so serious. I actually thought I bombed the interview, because, you see this guy on TV that is just larger than life. And then, he called me and he was just so serious, asking questions like, Jenni, what do you think about this? Or what do you think about that? And just the seriousness and sincerity that he had, like, I don't think I slept for 3 months waiting to see if I made this committee, because I truly feel they want to make a difference. And to be a part of that is it's just unreal to me that hopefully all of these voices of the patients, like I said before, I hope I can bring that to DC, so that, the patient I took care of in Huntington, Oregon, that was struggling, those are the stories in DC that need to be heard. If we're truly going to solve the problems, we have to correctly identify it and hear from those that are mostly influenced.
That's so fantastic. Before I forget, do like a little
Mhm.
commercial before we wrap. Do a commercial for Healthy Insights AI. Where can people find you? Where can people follow your work? Like, shout it out.
Absolutely. Thank you for that. Now that's the one question I probably wasn't prepared for. So number one, the easiest thing to do, I'm a terrible salesperson. So like they should not have me in sales, because I'd give it all away for free if I could, right? I mean, if it were up to me, like, let's build this, let's get it out there. Follow me on LinkedIn.
Yes.
Especially as I'm on this committee, I'm really hoping to post more to, work with people, talk with people. Follow me on LinkedIn. And then our website is healthyinsights.ai. As far as a quick elevator speech commercial, I guess what I would say is we are a neutral health risk assessment that is expansive, covering cognitive impairment and cognitive testing, social needs assessment. And then our aim as a company is to give an accurate snapshot or insight into the current patient condition, because then data becomes more than numbers on a page. It becomes actual things that we can use for proper care planning to really move the needle
Right.
on providing better outcomes and decreasing cost of care.
That's so great.
Does
We'll
that
make
work?
sure we put that. Yeah, it works great. It works perfectly. We'll make sure we put that in the description of this. And, you know, um, as you were kind of articulating your passion throughout the entire conversation today, I was like, I know exactly why you're on that committee. Because number one, you do have passion. Number two, you're curious, and you're like a lifelong learner. So you're like, hey, I don't know what I don't know. So you know what? Let me bring some other really smart people in here to kind of, and let me sort of sit within these lectures and actually sit with the students and actually learn with them. That there's a level of humility there that like we need to have ever present, now more than ever. So I'd say that they definitely appointed the right person, and having the voice of the clinician, the
Thank
voice
you.
of the nurse being there is pretty amazing. And yeah, I've just had a great time conversing with you. So for those of you that have been listening, and if you're hearing this, What a great story. What a great story if you're innovative and you're curious, where it can take you. I mean, amazing stuff. So if there is a topic that you want us to explore, or someone that you want to have come on the show, please drop us a comment. The way that you can support the community is, would you mind sharing this particular conversation, liking it, engaging with it? Maybe what stood out? Put that in the comments. We read them and like them. Again, this is a platform that's not just about content, it is about community. So thank you for listening. Keep building with purpose, and we will see you next time on the Advancing Healthcare Innovation Show.